We are recording the Fugl-Meyer Assessment of Upper Extremity Sensory Motor Function, motor sections A through D, in order to break down each subtest and explain the scoring for each section. This should help to improve inter-rater reliability. To start, we would like to mention that the Fugl-Meyer is considered the gold standard for upper extremity assessment after stroke or brain injury and has been widely used and researched since the 1970s. The Fugl-Meyer remains one of our required OT standardized outcome measures for stroke and brain injury patients here at Corewell Health, and every attempt should be made to complete this assessment. Per Stroke Edge 2, the Fugl-Meyer comes highly recommended in all rehab settings. It takes 20 to 30 minutes to complete and should be completed on initial evaluation and discharge or on treatment day 1. Of note, the Fugl-Meyer should not be used for patients with apraxia given difficulty with motor learning tasks. It is also important to note that the minimally clinically important difference is 10 points. This means that a change of 10 points in the assessment can be functionally meaningful to the patient. This assessment requires only the use of a reflex hammer, a pen or pencil, a piece of paper, a ball, a cylindrical shape such as a cup or a cone, and a stopwatch.
All right, so starting with the assessment, ideally you would like to have your patient seated in a chair without arms across from you. A score is given for the best performance, and each attempt should not exceed 20 seconds. It's also important to consider any orthopedic considerations for the assessment. For example, if a patient's had a prior shoulder injury or rotator cuff tear, and they can't perform part of the assessment, the score of 0 would be given for this, as well as an explanation provided as to why. So for the purpose of today's assessments, Jem's right upper extremity is going to be her affected side. With anything we're going to do, we're going to test the unaffected first and compare the affected to the unaffected. So for the first part, we're going to test reflexes. We're going to look at the bicep reflex first. We're going to have her instruct her to relax her arm, and as I support it and test your reflexes. Now I'm going to take the weight of her arm on mine, and I'm going to palpate that bicep tendon with my thumb. When I test her, I'm actually hitting my thumb rather than her bicep tendon. All right, that one looked intact. So then we would move to the affected side and repeat that same reflex. And so when testing the reflexes, we're looking for just a very subtle flinch in the muscle. We're not looking for big reflexive movements. It is simply either present or not present. Complete it and then move on. All right, and then we're on to the triceps reflex. For this one, we're going to have their arm relaxed, dangling kind of down by their side. We're supporting their humerus and the shoulder joint. They're slightly adducted, slightly internally rotated, and their elbows flexed at about 90 degrees. Again, I'm going to palpate with my finger where the triceps tendon is. And again, I'm going to tap my finger with the reflex hammer. So testing unaffected side first, then a little better view on this side. I'm right-handed, so I'd use my thumb over on this side. Moving on to the second subtest, we're going to look at volitional movement, the synergistic movement patterns, looking at the flexor synergy first. You're going to have your patient instruct them that they're going to test the unaffected side first, and you're going to demonstrate. Raise your hand toward your ear, bring your elbow up shoulder height, keep your thumb pointed up toward the ceiling like you're answering the telephone. With scoring, we're looking at several different aspects so that your patient wouldn't necessarily hold the position, but they would be able to do 3 attempts with this. So on one attempt, I usually try to look at the shoulder and the scapula position first, looking at the retraction. You're looking at that shoulder girdle. Are they elevated? Are they abducted and externally rotated? Next, you're looking at the elbow. Are they flexed? And are they able to achieve supination? All right, now we're looking at the second part of the volitional movement synergy pattern. where we're looking at the extensor synergy. So you're going to have that patient repeat the same movement they just had. And then this time you are going to tell them to raise your hand toward your ear, bring your elbow up to shoulder height, keep your thumb pointed upward. Now you're going to fully straighten your elbow, reaching across your body toward your opposite knee. Your palm will be facing downward like this. So for this one, you're looking at the adduction and internal rotation of the shoulder, elbow extension, and then can they achieve full pronation? All right, moving on to hand to lumbar spine. For this one, you're going to have your patient attempt with their unaffected side first. Place your hand to your low back. Good. All right, now let's try with the affected side. Bring your hand behind your back. Now for this one, for scoring, it's important that the patient is able to get past the iliac spine. For this one, when you're seated in front of them, you should actually be getting up and looking to make sure that they are able to clear that iliac spine. If they are not, that would be a score of a partial or a 1. And if they're able to fully get back there, would differentiate, give you a 2. All right, moving on to section 3, now looking at shoulder flexion 0 to 90 degrees. For this one, you're going to have your patient instruct them to fully straighten your elbow at the side, thumb pointing forward. Keep your elbow straight, raise your arm up to shoulder height. Do not bend your elbow as you're moving like this. You're demonstrating for them. Come back down. Reach up toward the ceiling. Good. So scoring on this one, a 0 would be there's no movement at all or partial movement. A 1 would be that there is some elbow flexion during the movement. And then a 2 would be that they are able to maintain that elbow fully extended up to 90 degrees. Again, for this one is where it's important to know your patient's orthopedic history with their shoulders. Again, with a rotator cuff or prior shoulder injury, that you are then scoring that as a 0 and then commenting in that section why they are not getting any points. So next we're going to look at section 3, pronation and supination. For this one, the elbow is going to be positioned at 90 degrees and the shoulder is at neutral. You're going to instruct your patient to place your arm at the shape of an L at your side without moving the rest of your arm. Turn your palm up as far as you can go and then down as far as you can, like this. Good. Okay, and then have them repeat that on their affected side. Okay. A 0 would be that they cannot achieve even the starting position because on this one we're not supporting that elbow. Or a 1 would be that they're able to have some movement, or a 2, they achieve that full movement. All right, and again, for the pronation and supination, it's important that you're comparing to that unaffected side, just given that different patients might have varying degrees of supination. All right, moving on to section 4, volitional movement with little or no synergy. We are next going to look at subtest shoulder abduction 0 to 90 degrees. For this one, the patient should be at neutral on their shoulder. Their elbow should be extended to 0 and their forearm is in a neutral position with their hand pronated. For this one, you're going to instruct them to rest your arm at your side, fully straighten your elbow, bringing your arm out toward the side to shoulder height. Keep your palm facing the floor. And again, you would demonstrate for them like this.
Okay, 1 partial. 1, 2.
All right, next moving on to subtest shoulder flexion 90 to 180 degrees. For this one, the patient would start with their shoulder at 90 degrees, their elbows extended, and their forearm is in neutral position. You're going to instruct them to hold their arm out straight in front of your body, straighten your elbow, point your thumb up toward the ceiling. Bring your arm up as far as you can go and back down. Okay. And then I'm repeating on the affected side. Okay. With this one, It's important again to note those orthopedic considerations with the shoulders comparing to the unaffected side. And then also really watching the elbow as they perform this one. If there is immediate elbow flexion, they will score a 0. If there's very slight elbow flexion through the movement, they'll score a 1. Or if they're able to maintain that and achieve the full range, it would be a score of a 2. For the 90 to the 180 degrees, if the patient was previously not able to achieve the 0 to 90, I think at that point you can infer that they would not be able to achieve the 90 to 180, and so you could give them a 0. All right, next moving on to pronation and supination, but this time with the elbow in neutral. For this one, you're going to have the patient flex their shoulder anywhere between 30 degrees and 90 degrees with the elbow extended. And you're going to instruct them to straighten your arm in front of your body like this. Keep your elbow straight. Turn your palm up and down as far as you can go. Okay, and have them repeat on their affected side. A 0 would be that they cannot achieve even the starting position, because on this one we're not supporting that elbow. Or a 1 would be that they're able to have some movement, or a 2, they achieve that full movement. Section 5, now we're going to look at normal reflex activity. If you remember earlier, we tested the reflexes of the bicep and the tricep just simply to see if they were present or not present. Again, in this section, you are only scoring in section 5 if they had scored a perfect score of a 6 on section 4. If not, you would mark that as a 0 and move on. If they did score a 6 in section 4, then you would be repeating the reflex testing again. But this time we're looking for any hyperactivity with those reflexes. So a score of a 0 would be that 2 or 3 of the reflexes are hyper reactive. A 1 would be that 1 is hyperactive, and a 2 would be that all are present and none are hyperactive. So that was completion of section A. At that point, you could score that section, or if an epic, you would just keep going and it would give you a breakdown of each section. All right, next we're moving on to the wrist. Again, looking at unaffected side first, affected side next. For the wrist, we're going to look at wrist stability with the elbow at 90 degrees first. Shoulder should be at neutral. Elbow will be flexed to 90 degrees and the forearm pronated. And a wrist in just a resting position. So you're going to instruct your patient to place your arm at your side in the shape of an L, like this, with the palm facing down. Without moving the rest of your arm, extend and hold your wrist upward, like this. So then you are looking to apply pressure. They should have at least 15 degrees of dorsiflexion in order to complete this. You're looking to see if they can maintain or they have the equivalent of a 3+ out of 5 on the manual muscle testing. That would give you the score of a 2. A 1 would be that they can achieve the position, but they cannot tolerate resistance. Or a 0 would be they can't achieve the wrist extension position at all. All right, so next we're going to look at wrist range of motion, repeated dorsiflexion and volar flexion. For this one, it's very similar to the prior one, but this time you're going to look at the volitional movement with this subtest. So you're going to instruct the patient to place your arm at your side, again in the shape of an L, palm facing down. Without moving the rest of your arm, extend your wrist all the way up like this and all the way down like this. Good. And for this one, you can help them by supporting at the forearm to achieve that position at the elbow. But the patient needs to be actively moving the wrist. You cannot assist with that portion. A score of a 0 would be that they can't achieve even the starting position, even with support provided at the elbow. A 1 would be that they have some degree of wrist movement, but it's less than that passive range. Or a 2 would be that it looks similar to the unaffected side. All right, next we are moving on to Section B, we're going to look at subtest stability at 15 degrees dorsiflexion with the elbow at 0 or in neutral. So for this one, the patient should have their shoulder flexed between 30 to 90 degrees. Their elbow will remain straight. Their forearm will be pronated. You're going to instruct your patient to straighten your arm but up in front of your body, keeping your elbow straight, extended, and holding your wrist upward. Wrist upward. There we go. Okay. All right, for this one again, you're going to apply pressure to that dorsal surface and seeing if they can maintain at least that 3+ out of 5 on the manual muscle test. A score of a 0 would be that they cannot achieve that starting position even at all. A 1 would be that they can get there but maybe can't tolerate that resistance, or a 2, they're able to take that full resistance. Again, with this one, you can assist by helping maintain that starting position. You're just not supporting the wrist as you actively resist. All right, next we are going to move down the list to wrist repeated dorsiflexion and volar flexion. Again, we're looking at the elbow in neutral with the forearm pronated. We're going to have the patient flexed between, again, 30 to 90 degrees. Again, you can bring them to that starting position if they need assistance with that. And you're going to instruct them to straighten your arm in front of your body, keeping your elbow straight, bending your wrist all the way down and up like this. Again, a score of a 0 would be the patient cannot achieve even the starting position, even with support provided at the elbow or the forearm, or no active movement of the wrist. A 1 would be that they are able to maybe get the position, and then a 2 that they are able to maintain and they have equal range of motion compared to the unaffected side. So wrist circumduction, last section under the wrist here. For this one, you're going to have their elbow, shoulder at 0, elbow at 90 degrees, and the forearm pronated. And you're going to instruct your patient to rotate the wrist, keeping the palm facing down. And with this one, I try to look at that they're hitting kind of 4 target points: the up, the in, the down, and the out. And that would give you the score of a 2 or the full points. A score of a 1 would be maybe there's some subtle wrist movement, but not full range, or a 0, meaning there's no active movement. So for this one, again, you can help them by achieving that starting position at that elbow to get the 90 degrees there. All right, so for the next one, we're going to look at section C, looking at the hand. For this one, again, elbow, all of these components, support can be provided at the elbow to help assist keeping it in that 90 degrees position, but no support is provided at the wrist. Again, you're going to compare affected to unaffected side, and then same thing, all of the objects that are introduced are going to be active grasp that you're looking at. So for the first one, we're looking at mass flexion. You're simply going to instruct them to make a strong fist like this. Again, scoring, either they have no ability to flex the MCPs or the IPs. 1 would be that there's some degree of flexion, but it's less than maybe 90 degrees. Or a 2 would be that it's equal, again, to that unaffected side. For mass extension, kind of the opposite, you're going to instruct them to open the hand as much as you can. Again, for this one, scoring would be a 0, no active extension at the MCPs or the IP joint. A 1 would be that there's any degree of extension, and a 2 that there is full extension present. All right, next moving down, section C, we're going to look next at the grasp aspects. We're going to look first at the hook grasp. Again, support can be provided at that elbow if needed. You are going to instruct them to have that elbow at 90 degrees, and their forearm can rest in a comfortable position, whether that's neutral or pronated, whatever they're most comfortable with. For this one, you're going to instruct them to make your hand look like a hook or a claw, and then you're going to say, don't let me pull your fingers straight. The force for this one for testing is the manual muscle score equivalent of a 4 out of 5, which would also indicate they're able to maintain that starting position. A 1 would be that they can maintain the position, achieve the hook grasp, but maybe they can't handle the resistance. Or a 0, they cannot achieve the starting position either at the elbow or with the hand. All right, so moving down to thumb adduction, we are going to have the patient with their shoulders starting in neutral, their elbow flexed to 90 degrees. Again, you're able to provide support at the elbow. The forearm and wrist and fingers are again in a comfortable position. We're going to be looking at the first MCP and the MPs, as well as the IPs, all extended to 0 degrees, with the thumb slightly adducted, excuse me. And we're going to instruct the patient to hold this piece of paper between your thumb and your index finger, keeping them both straight. Don't let me pull it away. Again, you're looking for a manual muscle grade score of a 4 out of 5, or the equivalent of that. That would give you your score of a 2. A 1 would be that they can handle the starting position, but the paper gives way. Or a 0, they can't achieve that position at all. Okay. All right, next we're going to move down the grasp, and we're going to look at pincer grasp with opposition. For this one, the patient again is at 0 degrees and the shoulder. You're able to stabilize and support them in 90 degrees at the elbow, and again, the forearm in a comfortable position. This one can be tested with the forearm in neutral or pronated, whatever is more comfortable for the patient. For this one, we are going to instruct them to take the pen from me with the pads of your thumb and index finger. Don't let me pull it away. So for this one, I'm pulling up. If she was pronated, I'd be pulling away or in. For this one, it's the equivalent of a 4 out of 5 muscle grade with that pincer grasp. That would give you your score of a 2. A 1 would be they're able to pinch it with the pads of their fingertips, but cannot maintain that resistance. Or a 0 would be they're not even able to grasp that pen or writing utensil at all. Next one we're looking at is grasping a cylinder. For this one again, shoulders in that 0 position, elbows at 90. Again, support can be provided at the elbow. Again, forearm in a resting or comfortable position. Okay. You're going to instruct them to take the cup from me with your thumb and index finger and middle finger. Good, and you're making sure that they're not gripping it with those last 2 digits. And don't let me pull it away. So I'm pulling up for this one. Okay, again, resistance of a 4 out of 5 on a manual muscle test would give you your score of a 2. A 1 would be they're able to grip the cup but cannot maintain that resistance. Or a 0 would be they're not able to achieve that starting position at all. Next, we're going to move to the last grasp section with looking at the spherical grasp. For this one, we're going to again have the patient's shoulder at 0, elbow at 90 degrees. Again, support can be provided at the elbow. And you're going to instruct the patient to take the ball from my hand with your fingers. Don't let me pull it out of your hand like this. Okay, and you're going to tug that. Again, you're looking for a manual muscle test grade of a 4 out of 5 to get a 2. A 1 would be they're able to achieve that starting position, gripping the ball, but can't maintain against resistance. Or a 0, they're not able to achieve that active grasp, spherical grasp. Last, we're looking at section D, coordination and speed. For this one, again, the patient is going to be seated. We're going to be looking at the unaffected upper extremity first, and then again comparing the affected to the unaffected side. For this one, we are scoring and looking at 3 different sections. We're looking at tremors, we're looking at dysmetria, and we're looking at the time difference between the 2 sides. You're going to need a stopwatch for this one, and you're going to instruct them and demonstrating again for them first. While keeping your eyes closed, bring your finger or your pointer finger to your knee, to your nose as rapidly as possible, 5 times. Do not start until I say go, and I am going to time you. And sometimes I'll just clarify and make sure they understand that 1 up and down is a full repetition. Good. And as she's doing this, I'm looking for any tremoring or kind of waywardness as she's coming up, which would give you your tremoring score. Again, is it marked? It would be a 0. If it's very subtle, it would be a 1, or if there's no evidence, it would be a 2. It's also important to note for this one that if a patient is flaccid, they still could, or has only maybe some partial movement, they still could score a 2 on this section if tremoring is not present in the upper extremity or with other movements. Looking at the dysmetria, we're looking to see if it's pronounced or if it's subtle. So when she's coming up to her nose, I'm looking to see how far off she is from her target. So 1 centimeter variation would be a score of a 1, or greater than 2 centimeters would be a score of a 0. Okay. And then you would repeat again on the affected side, and then you're looking at the time difference between the 2 trials, which would give you your score of a 2 if it's 2 seconds or less as far as difference, a score of a 1 if it's between 2 and 5 seconds, or a score of a 0 if it's greater than 6 seconds. So next we're going to look at section H, moving on to sensation. For this one, just briefly looking at light touch, it's important to just make sure you're being thorough with that light touch, that you're using either a light brush or a cotton swab, something that is not giving proprioceptive input as you're testing, and that you're testing kind of randomized sections through the upper extremity and then the dorsum of the hand. And making note of their accuracy for that. A score of a 0 would be that they are not able to identify that at all. A score of a 1, that they would have 3 out of 4 correct, or a score of a 2 would be 100% correct. And then you would turn them over and you're going to test, again, just the palmar surface of their hand, again with the same scoring. Moving on to positioning, or looking at proprioception. This one's a little bit more difficult. You're going to be looking at 4 different joints through the upper extremity. First, for the shoulder, again, giving them instruction just to kind of relax that arm, and again, thinking about your hand placement as the therapist so that you're not giving them that proprioceptive input as you're testing, keeping your hands in more of a neutral position. And then having them close their eyes and identify, again, with a relaxed arm, what position their arm is in. Jem, is your shoulder up or down?
Up.
Okay. Is your shoulder up or down?
Down.
Good. And with all of these proprioception tests, just again, consider your patient's language abilities too. If they have aphasia, maybe they could do more of a mirrored position. They could give you thumbs up or thumbs down, whatever is most accurate with their ability to communicate. For elbow testing, again, you would have them relax that arm, hands kind of on the side, again, able to position, and make sure that you're not testing that kinesthesia, but that you're truly testing proprioception. For wrist, same thing, kind of up or down position. And then for the thumb, you're looking specifically at that IP joint. All right, so for section J, passive joint motion, typically before you would even start the Fugl-Meyer, you should already know what your patient's active and passive range of motion are from your initial evaluation. However, just important to mention that if they are fairly flaccid or have a subluxation of any sort, just a reminder that you're not going past that 90 degrees if they are not actively able to go past 90 themselves. And then for joint pain, I simply am kind of just asking, and at the end of the assessment, were any of those painful for you? If yes, you're making note of which ones, and maybe just retesting those range of motions as well. Again, that will give you a complete and final score. Please make sure that you're filling in every section in order to get that final score, as that's carried through the continuum with them.